You're watching Salina Media Connection. Jodi Schmidt, Executive Director of the CARE Collaborative at the University of Kansas Hospital, gave a presentation Thursday, October 31st, 2019, on the state of healthcare in rural Kansas. The presentation took place at the Salina Country Club during the Salina Regional Economic Outlook Conference. The following presentation will last about 23 minutes.
Thank you for the opportunity to be here today and talk a little bit about the state of rural hospitals around Kansas. I will say that I have been with the University of Kansas Health System for nearly 5 years now. Prior to that, I started back in 1987 working with rural hospitals and helped many of them convert to critical access hospital status. I'm new to the world of academic medicine, but our project is really focused around connecting with and supporting rural facilities across the state. Phenomenal resource. I know he's going to do wonderful things during his time here. Fortunately, they allowed us to keep 25% of him for some medical directorship in our work. And so really pleased to share a bit about our learnings. The truth is, I wish I had better news, but in Kansas, our rural hospitals are at risk. So we'll talk a little bit about the economic indicators that suggest our rural hospitals are at risk, and then about some unique solutions that we've been working on to support that. So when we talk about the current reality of where we are as our rural hospitals, the challenge is very distinct. We have decreasing patient numbers, as we saw in some of the presentations this morning. The realities in rural are felt by our rural hospitals. And in truth, when we talk about what's going on with our rural hospitals, to some degree we're propped up a little bit in the short run because as we age, we use twice as much health care. And the reality is we have an accountable care organization at this point in time, and our average age compared to other Medicare beneficiaries around the country, we are 5 years older in our rural participants right now today. So that has helped prop us up a little bit in recent years. But the reality is we have hospitals with very, very low average daily census, less than 2 patients. How do you sustain your hospital with less than 2 patients in bed? But the reality is those patients still need emergency room services. They still need physical therapy and respiratory therapy and outpatient services. So we'll be talking a little later about some new models that perhaps rely less on inpatient care and more on what communities truly need to stay healthy. But we also know that healthcare plays a really important role in the economic engine of a community. In most of the communities that we work, healthcare is either number 1 or number 2 in terms of total employment in the community. We also know that healthcare is really important to the viability of high-wage jobs, because in healthcare typically our wages run a little higher than in other sectors of the economy. So we know it really is important for us to sustain the economic engine from a healthcare perspective. To give you just a little bit of a breakdown of inpatient bed declines, now you will see that, again, like the other speakers, when we talk about rural and federal designations, it's everything in Kansas outside of Kansas City, Topeka, and Wichita. Everyone else, including Salina, Garden City, Hayes, those are all considered rural as well. Now, so of course when we say more than 5 patients a day, those are the hospitals that we're talking about. But when we start talking about 1, 2, less than 3 patients a day, those are our very smallest communities. But in truth, our regional hubs, our regional referral centers, like here in Salina, do depend upon the existence of those regional hubs. Those providers handle primary care and then refer into their regional hubs for the next level of care. So it has a negative impact. Just in the way we talked about retail sales being down in a rural area impacts those larger urban markets, we see that in healthcare as well. For the University of Kansas Health System, yes, we are an academic medical center in Kansas City. But the truth is we are the academic medical center for Kansas, and although we separated from the state in 1998, we at that time made a commitment to the state legislature that we would work to improve the health of Kansas. And that's why this work is so important to us. And to be quite frank, 20 years ago, when we separated from the state in 1998, we were in a very similar position to the position of rural hospitals today. In the late 90s, 70% of our beds were empty. Today, on any given day, we may be running full. And the work that we do around the state is not about bringing more patients to our campus in Kansas City, because we are full. But in the late 90s, we were not. We were projected at that time to lose $20 million in 2000, and every year thereafter, we were struggling to attract patients, struggling to attract providers and staff to obtain supplies. We had to change the public perception of how care was delivered. We were in the same boat that many rural hospitals are today. And what we found is by focusing on the delivery of high quality care, we could change that, and we could change our financial trajectory by really focusing on how we deliver very high quality care in a cost-effective way. And so we are committed to improving the health of Kansans through improvement of the Kansas hospitals and using the same learnings that we had over the last 20 years. Today, we are the best hospital in Kansas, ranked by U.S. News and World Report. We are the best hospital in Kansas City. We have phenomenal patient satisfaction of above 95% in any given quarter. We have been able to turn it around with the right sort of focus. And so it is not an easy road to hoe. It didn't happen overnight. It was 15 years of hard work before the trajectory really started moving forward, and now we're building on that. But we do believe that if we can provide the right support to our Kansas hospitals, we can see that same sort of change. We are Kansas. We continue to have capabilities that we want to share around the state. The Kansas Heart and Stroke Collaborative is one of those, and I'll be talking very specifically about that work. We were having a conversation earlier. Folks asked me, so we know that first you acquired Hayes and then Topeka and most recently Great Bend. So are you looking to take over the state? And the reality is no. We don't have the resources to take over the state, but sometimes we can help in a given community. And it made more sense for Hayes Medical Center to work with us as they were exploring partnerships than for them to connect in Colorado. We are Kansas. And when St. Francis, Kansas, it was announced that they were going to close that facility, it made sense for us to be part of that solution. I did spend 9 months as the interim CEO at Great Bend. That was an opportunity for us to bring the community together after more than 15 years of competing entities within that community, because together we could really bring the staff together, shore up the human resource gaps, be able to really address the needs of the patient together. So I will say very specifically, we are not out to control the state. We are not looking to acquire every hospital in Kansas. What we are looking to do is say, how can we measurably improve care, and where does it make sense for us to have that type of relationship? But in general, the Care Collaborative is about the relationship for those who are willing to put in the sweat equity. There is no cost to being part of the Kansas Heart and Stroke Collaborative. In fact, we received a grant from the Center for Medicare and Medicaid Innovation to do this work. And it allows us to reach out and connect and bring evidence-based protocols and practices and templates and boots on the ground support and training in the local community, so we can train all the nurses, all the physicians, all of the EMS providers, long-term care, all in one fell swoop around the very latest research. Typically in healthcare, the newest research takes 10 to 12, sometimes 15 years before it becomes the standard of care in our communities. And we really felt that was much too long. And in our rural areas, there was no reason that we should have the same highest quality, state-of-the-art care that we have in our urban facilities. And that's what the collaborative was about. And we were so successful in focusing on heart attack and stroke that we were able to then expand it into sepsis and heart failure. We're now adding trauma, particularly here in central Kansas. It was the rural hospitals here in this region that said, we want to be level 4 trauma facilities. We want to have all those capabilities. It's tough for us. Would you add trauma to the work that you are doing? And it came from right here in this region. And we've done a great deal of work with Salina Regional. They've been a tremendous partner in terms of chest pain accreditation, stroke accreditation, continuing to think about how can we connect the small critical access hospital and their regional hub around that same level of highest quality care. We also said, we found through our work that we were saving the Medicare program money. And why should that all sit back in Washington, D.C. and Baltimore? Couldn't we bring some of that back into our rural communities? So we formed an accountable care organization under the Medicare Shared Savings Program. And so in 2018, we were able to bring $2.3 million of shared savings back to our rural communities through the Medicare Shared Savings Program. This past year, we achieved more than 93% on our quality metrics. So we are proving, there are folks back in Washington, D.C. that say it's okay that rural hospitals are closing because they can't really provide the same high quality care anyway. And so our Medicare patients need to go upstream to the next facility. We are proving that we are doing better than the average, that we can do it better in rural, and that's really a lot of what we're focusing on. And we want to think about what could a new healthcare system for Kansas if we can't sustain every rural hospital. And we have lost some already here in Kansas. We've seen what happened in Independence and Fort Scott when they lost their hospital. Now there are 3 more up for auction very shortly in 3 Kansas communities that have closed their hospitals, and their hospitals are up for auction. We know that there are continued challenges, and I'll show you some data around how many in Kansas are at risk. But we said if we connect through the right work, we can change that trajectory. We started out in 13 Northwest Kansas counties. We call them the original 13 colonies. We were so successful in those 13 colonies, Medicare Innovation Center said, can you prove that you're able to replicate that work elsewhere in the state? And so we came here to Salina and met with the Sunflower Health Network of rural facilities and Salina Regional, and they said, we're interested in this work. So they came on board. And then folks down in Southwest Kansas said, we have an interest. And it has grown to the point that we are now in 68 organizations across 60 counties. More than half the state of Kansas is participating in the Care Collaborative. And we've been able to demonstrate that we can sustain that work while we continue to grow it. I'm not going to dig into these quality metrics. I know it's hard to see. What I will tell you is the center line is where we started on things like timeliness of EKG if you're having a heart attack, timeliness of CT if you're having a stroke, how long it's taking us to get you a thrombolytic. Less than 3% of rural patients in Kansas were getting a thrombolytic for their stroke when we started. Last quarter we were at 33%. When we look at sepsis, when we added sepsis, it was a big city Kansas physician who said, what about that other time critical diagnosis of sepsis? We started out just a little over 60% of the time were patients getting accurately diagnosed with sepsis. It is truly the leading cause of death in Kansas because it can impact patients across diagnoses. We are now up to 94.8% of the time we are accurately identifying sepsis in our rural communities. So what this graph tells you is we really can make a difference and really can improve the identification of sepsis patients, really measurably improve the time it takes for you to get your stroke or your heart attack managed. And we were able to do it and have patient and clinician satisfaction. What we heard so often is we have to send our patient upstream to the next level of care, we get no communication back. You guys bring this into Kansas City and say, here's the wonderful new evidence. Go forth and do. And then we go back home and we're overwhelmed by the patients in our beds and the response to the ER, etc. And so not surprisingly, the old-fashioned way of doing continuing medical education only truly changed care less than 10% of the time. But by bringing it to the local community, bringing protocols, bringing practices, we actually come in and do the data abstraction to support them in understanding how well they're performing. We're able to achieve 90, 95, 100% satisfaction in the participants in our work. This was actually a study done by the federal government at Mathematica to demonstrate that the folks really found it beneficial. And as I said, we were able to bring $2.3 million of shared savings back from our 2018 results. And we've continued to grow. We now have more than 33,000 Medicare beneficiaries that we are responsible for in the work that we're doing. These are rural only. Kansas City is not part of this work. These are rural beneficiaries who are part of the work that we're doing. One of the things we established and works very effectively, particularly in this region of the state, is chronic care management. We have a team of health coaches who provide ongoing monthly support services to folks with chronic conditions. We have actually found that we can also do that via telehealth. Yesterday, a group of patients in Beloit, Kansas, and a coach in Coffeyville, Kansas, held a heart failure training for an hour and a half, talking about their diagnosis, their disease state, how they were managing it, and they talked with one another about how they support that work, and we were able to do that via telehealth very successfully. Those are the sorts of things that we're able to do to really expand the capability of what we're able to do in our rural communities, even though in most of our rural communities we have a real shortage of nurses. Not every community could dedicate someone to do this kind of work. But if we do it in a collaborative manner and we use technology, we really can move the needle. We also found that now we can add remote patient monitoring. So we can identify what's going on with the patient in their home day in and day out between that every 3 or 4 month physician visit. And what we found is doing the right thing for quality and doing the right thing for patients is also good business. A 21.3% reduction in total cost of care for patients that are receiving those chronic care management services, which is all about sustainability. We talked a little earlier today about how anything that we do has to be economically sustainable. And those are billable services that allow us to sustain the work we're doing as well. So if we're successful in terms of being able to say, let's stabilize what we're able to provide, let's bring workforce from outside communities if we're short in workforce in our own communities, what can a new system for Kansas look like, given the fact that we have such a dramatic number of hospitals at risk? And so we have really worked with leadership around the state, particularly Kansas Hospital Association, Kansas Medical Society, and others, to say what would a new model for healthcare in Kansas look like, and what would our areas of focus be? How could we still keep care close to home? We know healthcare is personal, and our patients have to have access as close to care as possible, but we also know that we want to practice best practices. We need to maintain rural emergency room services, and we can't forego outpatient services. There are some states that have gone to an ER-only model. That's what we have in our rural communities, an emergency room and nothing more. But what happens when I need respiratory therapy because I'm a patient with COPD? What happens when I need physical therapy because I had my knee or hip replaced back at the regional center, but now I have to get therapy locally at home? And so we really believe that we've got to support outpatient services as well. We know that not everybody who needs inpatient services, they may only need some observation, they may only need some fluid, so we shouldn't have to move everybody around those services. We need for them to have a partner, much like you do in this region, in that partnership between Salina Regional and the rural facilities. We know there's got to be increased partnership. We know we've got to have more EMS. When the Independence Hospital closed, they're part of our work, we were able to look at the data and the claims data and say specifically that the number of EMS transports tripled. And in some cases, for some of the higher acuity needs of those patients, it quadrupled. The EMS service couldn't handle that in terms of a tripling of their calls overnight, and it required a regional response from EMS. All across our rural communities, we have relied upon volunteer EMS services. And there are fewer and fewer folks able to step away from their employment positions and be volunteers for EMS. So we're really going to have to focus on a new EMS system across Kansas. And then, as I said, build on the work that we've done. It's really grounded in our partnerships and how we work together. When I was first asked to present this slide deck, 73% of rural hospitals in Kansas had a negative operating margin. And 2 weeks ago, the new data came out, and it is now 80% of rural hospitals in Kansas have a negative operating margin. Kansas and Tennessee are the two states with the highest rate of communities unable to demonstrate a profit at their local hospital. Now, of those hospitals that are at risk, and how did we define those hospitals at risk? There's actually a national firm through the National Rural Health Association called Chartis that looks at the 118 hospitals that have closed in recent years, rural hospitals, and all of the economic indicators. And then they compared it to our Kansas hospitals on all of those same indicators. And that's how they defined at risk. 25% of our rural hospitals today in Kansas are considered at risk based around those standards. Now, I often get asked, can you give me a list of who those are? And in truth, I can't, because the researcher said the one thing we cannot predict is what is the willingness of the local taxpayer to make a financial contribution or increase a financial contribution to keep that hospital open. And that's why I can't tell you who are those 25 communities, because I can't predict for you which of those communities are going to step up and fill the gap and which might not. But what I can tell you is right now today, there are 25 communities at distinct risk of failing to be able to meet the needs of the community. And that's why we believe it's very important for us to partner as a state and find the right solution, the right model. We're continuing to work with our senators about some new federal models that would sustain the work that we've been discussing around a rural facility that's an emergency room with outpatient services and population health services, but maybe not inpatient beds. We're working with the Center for Medicare and Medicaid Innovation to try and talk about what such a model could look like, and to be given the flexibility today to be a hospital, you have to have inpatient beds, to be given the flexibility to start looking at how could it look differently. The other question I get pretty frequently is, what about the impact of Medicaid expansion? I cannot tell you today, quantify for you exactly the impact of Medicaid expansion. That research is going on right now today. We have asked to look at the rural hospitals in Kansas versus a comparable state in Iowa that did expand Medicaid, and let's quantify the impact of Medicaid expansion. I don't have those results for you today. What I can tell you is it would absolutely help our rural hospitals if we had expanded Medicaid. The most closures around the country have happened in states that did not expand Medicaid. And we hope to have the research very soon to quantify that very directly. The other question I get pretty regularly is, do you really believe a new model can work? And the truth is, because I've been around a long time, the last round of rural hospital closures happened in 1987, and from that came an Each Peach demonstration that Senator Dole included Kansas in, very fortunately, and I spent 5 years working on that project in western Kansas and connecting with his office around how to structure such a program. That became the critical access hospital program that has sustained our rural hospitals these last couple of decades. So I believe that because I have seen it, a new federal program that created critical access hospitals did allow us to sustain that work. And so I really do believe that with the right sort of structure and federal support, we can make this work long term. I'm probably out of time, maybe a little over.
Thank you so much.
That was a presentation by Jodi Schmidt on the state of healthcare in rural Kansas. You're watching Salina Media Connection.